Okay, so can I just say how proud I am of Paula Barry? I'm so pleased to see those results finally presented. That was a fantastic presentation. And thank you for the lovely introduction, Sue. And I'm delighted to be here today to present to you about interventions for fear of childbirth. And really, this is the culmination of my PhD, which I completed in 2019. And I completed my PhD at University College Cork. And before I go ahead with my presentation, I'd like to acknowledge my doctoral supervision team, Dr. Ali Kashan, Professor Patricia Leahy-Warren, Dr. Sinead O'Neill, and Professor Louise Kenny. And I'd also like to acknowledge all of the participants in my research, because of course, no research would be possible without the participation of pregnant women. And it's just so important to acknowledge them. I'd also like to acknowledge the HRB who funded my Cochrane Fellowship, which was Interventions for Fear of Childbirth. And so today I'm going to talk to you all about how we can manage fear of childbirth, which we know is a prevalent issue for women. And so I'll go ahead. So childbirth is a fundamentally human, life-altering and meaningful time. Women hope for a joyful and positive birth experience. However, the birth process is uncertain, so it's normal to experience anxiety, worries, or childbirth-related fear. And we have this meta-synthesis from Sue Down and colleagues who told us what women want from birth. And what they want is a positive birth experience and to give birth to a healthy baby in a psychologically safe environment. And they want to feel safe and that psychosocial well-being is equally valued with safety. And really, we should be designing maternity care to fulfill or exceed women's wishes. So how can we as midwives facilitate a safe and positive birth? Or as Sue says, both and. So if women are prepared, supported in their choices and have respectful maternity care, even an emergency situation which could be perceived as traumatic may be experienced as positive for the woman, and fear can be reduced in subsequent pregnancies. So a positive birth experience can actually be healing as well for someone who's had previous birth trauma. And we know that keeping midwifery care respectful and individualised increases positive perceptions of the birth experience. And it's really important to keep the woman at the centre of care, leading her care, acknowledging her attitudes, cultural values and beliefs. So we had this landmark publication in 2014 from The Lancet, which highlighted perinatal mental health as vital for women in the perinatal period. And the first of the three papers examined non-psychotic mental illness, such as depression, anxiety, and post-traumatic stress disorder. And fear of childbirth comes under the umbrella of anxiety disorders. So this is relatively newly acknowledged in terms of research. So how can we define fear of childbirth? And actually, it's really challenging. So broadly speaking, fear of childbirth comes under the umbrella of anxiety disorders. And like I said, it's normal to have a certain level of fear during pregnancy. And fear exists on a spectrum from low to high. And at the top end of the spectrum, you have phobic fear. But in terms of research, if we look at the literature, various terms have been used interchangeably. And I would say the same is true of clinical practice. We talk about fear of childbirth. Sometimes we talk about childbirth-related fear, tocophobia, myusiophobia, lochiophobia. There's actually many different terms that we use for fear of childbirth. And like I said, levels of fear can fluctuate during pregnancy, but they usually increase as birth becomes imminent. Common fears experienced by women are safety concerns, fear of pain in labour, fear of the unknown, fear of being left alone in labour, or fear for the baby's health. In the year 2000, two psychiatrists, Hofberg and Brockington, coined the term tocophobia. And they classified tocophobia, or severe fear of childbirth, into primary, which affects women who've never given birth before, secondary, which is usually subsequent to a negative birth experience or birth trauma, and secondary to depression. And what is the impact of fear of childbirth? So, in ancient times, primordial fear served a purpose. A fight or flight response is triggered for survival. So when you come in contact with a feared stimulus, there is a physiological response to the fear. The amygdala or fear center in the brain is triggered, and this releases hormones such as cortisol and adrenaline, the stress hormones, and this can affect the ability to make decisions. This is crucial for women in labour because it can impact their decision making around labour and birth choices. For some women, fear of childbirth is so extreme that it is incapacitating. It negatively impacts their sleep and can cause anxiety and depression. Avoidance behaviours characteristic of phobic states might be experienced. Antenatal appointments might be missed. Engaging with conversation about the pregnancy or baby might be avoided, and preparation for birth or motherhood avoided because of feelings of disgust or fear of the process. It might be difficult to talk to their partner or family about, and this can cause feelings of isolation. A severe fear of childbirth is associated with lower birth satisfaction, negative birth experiences, and postpartum post-traumatic stress disorder. Infant bonding issues can also be experienced. Importantly, fear of childbirth can also be passed on through generations from mother to daughter, affecting self-efficacy in the ability to give birth. So you look at your mother and you think, well, she couldn't do it. I don't think I can do it. Fear can juxtapose a balance of risk avoidance and risk taking, meaning that some women will mitigate their risk by having more medical interventions and choosing a caesarean birth. Fearful partners can also influence birth choices. Nevertheless, even if they have a caesarean section, fear may not resolve and women may still experience birth trauma or low birth satisfaction if adequate support is not received or if they have a negative encounter with a healthcare professional. Some women may fear unnecessary intervention, lack of control, or not being involved in birth decisions, conversely. An Australian study found that there were 3 groups of women. Those who were fearful had safety concerns and high level of fear, and they tended to opt for a caesarean. Those who take it as it comes, and then self-determiners who had low levels of fear and perceived birth as a natural process. So how common is fear of childbirth? So in 2017, we published a systematic review and meta-analysis, which looked at the global prevalence of tocophobia, or severe fear of childbirth. And we found a prevalence of 14%. However, this estimate does not include the women at the phobic level of fear who were so fearful that they chose not to get pregnant or had an abortion due to fear. A lack of consensus on definition was found and high heterogeneity amongst prevalence studies was noted. What this tells us is that the issue is extremely complex. There were a variety of measures used, and the Weijma Delivery Experience Questionnaire Part A, which is recognised as gold standard, is cumbersome. It's not easily understood by women, and now there is doubt that it actually encompasses relevant concepts. Nevertheless, it's still the gold standard that we use, and we use a cutoff of greater than 66 for high fear and a cutoff greater than 85 for severe fear. So we can see that the terms tocophobia and fear of childbirth remain poorly defined and are used to encompass a broad range of emotional challenges related to anxiety and fear in pregnancy. So how common is fear of childbirth and tocophobia in Ireland? So we published this study in, when was it? 2019. And this was one of the main studies from my PhD. And it's available for open access online if you want to access it. So this was a cross-sectional study which we conducted in Cork University Maternity Hospital with full ethical approval. And you can see all of the details of the study there. We estimated prevalence and associated risk factors, and we also looked at 4 WDEC subscales within the questionnaire. That questionnaire has 33 questions, so it's quite long for women. So in total, 882 complete responses were received, which was a high response rate of 75%. And you can see that there was a high prevalence of high fear of childbirth in this Irish sample. So 36.7% of women had high fear of childbirth, and 5.3% of women had severe fear of childbirth. If you look at the comparison between nulliparous women and multiparous women, severe fear of childbirth was not statistically significant, But the difference between nulliparous women and multiparous women with high fear of childbirth was statistically significant. We found that women who identified as single were more likely to have high fear of childbirth, and this was similar to findings from previous research. And we also found a statistically significant association between high fear of childbirth and depression. The finding that low perceived informational support increased the risk of high fear of childbirth almost threefold is important, because this factor might be potentially modifiable. We can help women to have better informational support. Within this questionnaire, we looked at 4 different subscales, which I'm not going to go into in detail here, but it's important to note that we should be looking at the nature of the fear as well as the severity of the fear. So in conclusion, this study found a similar prevalence of severe fear of childbirth, but we actually had a higher prevalence of high fear of childbirth when compared with reported international prevalence. Again, high fear of childbirth was associated with depression, being a first-time mother, and low perceived informational support. So we need to assess social support, provide antenatal education and high quality information in pregnancy. We also acknowledge the limitations of study, which are that it was a single site study and a convenience sample, and actually the study was designed for primarily to estimate the prevalence, so it may have been slightly underpowered for the risk factor analysis. Nevertheless, it's the first study of fear of childbirth in Ireland, and so we can, has value. Okay, so how can we support women with fear of childbirth? What kind of interventions or treatment are available? So women routinely attend midwifery counselling in Sweden, which are the leaders, I suppose, in terms of research with fear of childbirth. It's normal for women to talk about fear of childbirth, and they're assessed at the booking in Sweden. And they set up midwifery counselling in response to a clinical need. This counselling involves a visit to the labour ward as a kind of exposure treatment, and women are also taught strategies to cope, such as breathing techniques. The UK and Ireland have begun to introduce support for women with high childbirth fear, but there's a disparity of approaches and availability of care due to a lack of consensus on the underpinning theory and etiology, and we spoke about that. In terms of research, though, several interventions have been studied. So today I'm going to present to you, for the first time, the main findings from our Cochrane review on interventions for fear of childbirth. I'm not going to present all of the subgroup analysis today, just the main findings. Okay, so the aim of the review was to establish the effectiveness of non-pharmacological interventions for pregnant women with fear of childbirth compared with standard maternity care. And we used the standard search methods for Cochrane, looking at their Cochrane Pregnancy and Childbirth Trial Register, clinicaltrials.gov, and the World Health Organization International Clinical Trials Registry platform, as well as the reference lists of retrieved studies. The women who were included had higher severe fear of childbirth, and we excluded quasi-randomized and crossover trials. We planned to examine anxiety as an outcome, but actually none of the eligible trials reported a measure of anxiety as an outcome, which was slightly surprising considering that fear of childbirth comes under the umbrella of anxiety disorders, and some of the attributes of fear of childbirth and anxiety would overlap. So the PICO for the review were, as you can see, the primary outcome was fear of childbirth, and the secondary outcomes were caesarean birth, EPDS, which is a measure of postnatal depression, anxiety, preference for birth, epidural, and childbirth self-efficacy. As I said, we used standard methodological approaches recommended by Cochrane. 2 review authors independently extracted data and assessed the studies for risk of bias. And then a 3rd review author checked the data analysis for accuracy. After this, we used GRADE to assess the certainty of the evidence and classified results into very low certainty, moderate or high quality evidence accordingly. So these are the main results. So we found 700 records in total, and after we removed duplicates, there were 463 records screened. We excluded 348 records that were not a trial or within the scope of the review, and then we assessed 115 reports for eligibility. 52 trials were excluded with reasons that were usually because the definition of fear of childbirth was not clear or using a validated measure. And so in total, we had 10 reports from 8 trials included in the final review. This encompassed a total of 947 women. And overall, the studies were at high or moderate risk of bias. One study was at low risk of bias. So the certainty of the evidence was assessed as low or very low, and this was downgraded due to risk of bias, imprecision, or inconsistency. Actually, the trial sizes were very small. So the studies included were from Australia, Sweden, Iran, and Turkey, and were published in English. So you can see that there's quite a limited amount of evidence in relation to interventions for fear of childbirth outside of Sweden, Australia, Iran, and Turkey. And you can see that there's been an exponential interest in the topic because 4 were published in 2020. You can see 2020, 2015, 2014, 2018, 2012. So it's definitely growing interest. And the interventions under evaluation were psychoeducation, group or individual, internet cognitive behavioural therapy, art therapy, and one study had 2 intervention arms, peer teaching and group discussion. In the Waldbeck study, the art therapy was an adjunct to midwifery counselling because this is the standard in Sweden. And so in the control groups, this also affected that because usual maternity care for fear of childbirth in Sweden is midwifery counselling. So 4 of the 8 trials had midwifery counselling as the control group. And one study had antenatal education in the control group. So these are the main results. And so you can see that based on the findings from the review, there's not strong evidence in support of any of these interventions. Psychoeducation seems to consistently reduce fear of childbirth, although the quality of the evidence is low. Midwifery counselling aims to work through women's individual fears and develop a birth plan, and this seems to be beneficial for women. We're uncertain if internet CBT is more beneficial than usual care. We had 1 trial of 200 women with low certainty evidence. Peer teaching and group discussion might be effective in reducing fear of childbirth. So overall, you can see that the findings of the meta-analysis indicated women who participated in these non-pharmacological interventions for fear of childbirth experienced a reduction in mean fear of childbirth, but the quality of the evidence was very low. We had evidence from 8 trials and 947 women only. So you can see that women who participated in interventions may have fewer cesarean sections, more preference for a normal delivery, less preference for cesarean section. They had similar depression outcomes, and they had slightly more epidural rate. But the epidural, if you look at that, it was 35 more per 1,000 epidurals. And this came from only 2 trials with 380 women and low certainty evidence. So overall, there's not a strong certainty of evidence in relation to the interventions for fear of childbirth. So in conclusion, attending any intervention had a positive effect on fear of childbirth overall compared with usual maternity care. Women who participate in interventions for fear of childbirth seem to have lower preference for cesarean section and more vaginal births. But some studies compared the intervention with midwifery counselling, which is the usual standard of care for women with fear of childbirth in Sweden, so that needs to be acknowledged. So we need more high quality evidence in order to gain a better understanding. Okay, so moving from the quantitative, I want to now talk about the qualitative, because obviously one will complement the other. Because while quantitative approaches have been used, there's a lack of qualitative evidence on women's experiences of interventions for fear of childbirth. And qualitative approaches might facilitate more depth of understanding of complex experiences than quantitative data. And this definitely is a complex experience. So again, this paper is published. It's actually my first time presenting it because actually because of COVID, I had planned to present this at the ICM last year, but it was unfortunately cancelled. So this is a meta-synthesis that we performed in 2019 to conduct a review and synthesis of qualitative experiences for fear of childbirth in the perinatal period. So we wanted to know, how did women actually experience the interventions for fear of childbirth? So we carried out the metasynthesis in the normal methodology. Following independent quality appraisal by 2 authors, 7 qualitative studies were eligible for inclusion. These studies revealed the various experiences of women who attended the different interventions, and we integrated the findings using thematic synthesis. Okay, so what studies were included and what kind of interventions? So we had 3 Norwegian studies and 4 Swedish studies. And the types of interventions that were looked at were continuity of care, team midwifery. We had internet cognitive behavioural therapy. We had 5 weeks of art therapy, and that study was also included in the Cochrane review. And in that study, they also had a combination with the specialist midwifery team, which involved a visit to the birth environment and a review of past notes as relevant. And then another study reported on midwife-led counselling, which involved information giving on the birth process, learning techniques to cope with labour, and again, a review of the birth notes is necessary for women with a previous negative birth experience. 4 of the 7 studies included continuity of midwifery care as part of the intervention. There were 137 women in total in this study, and the sample size ranged from 5 to 27. And again, there were many different definitions for fear of childbirth used. So 2 used the WDECA greater than 85, 2 used the fear of birth scale greater than 60, and 3 used the self-reported fear of childbirth. Okay, so these were the themes and subthemes that were generated through the synthesis. And the overarching theme of the synthesis was moving from fear to ownership of childbirth. So the interventions helped women to move from this feeling of incapacitating fear to taking ownership and being active in the process of childbirth. Participants felt that it's a topic which is difficult to speak freely about, but the interventions helped women to articulate and acknowledge their fears. When women were easily able to talk about their fears, they had increased agency and were empowered. They were able to put a plan in place and be supported in pregnancy and birth, realising that they could cope, even in the face of adverse events. Having an advocate in labour was important to them. For this and many other reasons, continuity of midwifery care was helpful. Partners Interventions helped women to share their feelings with their partners and be taken seriously. It's important to recognise that the fear didn't resolve, but women learned to manage their fear with a sense of security when they were empowered, had trust in their caregivers, and were given the right support. An important finding is that women valued having a trusting relationship with their midwife and/or doctor, and a belief that they will receive compassionate and respectful care in which they lead decision making. So I'll take you through the themes and the sub-themes now. And the first theme was facing the fear. So the first thing that women needed to do to face the fear was to acknowledge that they actually were experiencing fear. And the interventions helped women to actually feel that they were able to express and face up to their fear. And this was a crucial step in the journey to ownership of childbirth. This woman said, "Before it felt like a lump in my throat because I wasn't able to communicate this difficult feeling." And she was a participant in art therapy. And the second woman said, "If you get to put it into words, it exits the body and you can ground your thoughts in some way, and then you can let it go." And she was a participant in the midwifery counselling. But it's vital that healthcare professionals also need to acknowledge the fear and take the fear seriously. Sadly, in several examples, women perceived that their needs were not met, and healthcare professionals lack sensitivity or compassion. And the second sub-theme, moving to facing the fear, was actually needing to identify the fear to identify the woman's needs. So we call the sub-theme identifying the fear. And this woman said, she, the midwife, knew what I was afraid of. I had an appointment and I could talk about it before the birth. The team of midwives had time to focus on the birth and my feelings about it. And she was a participant in the team midwifery. And then another woman said, "It also made it easier to talk to my husband. Before it was difficult to put it into words. He knew that I was scared, but not how I was scared, how it really was for me. Then you could talk about this, and it made it easier for him to understand. And that was a participant in the art therapy. So moving on from facing fear, second theme was feeling empowered. So women moved from facing the fear to feeling empowered through the interventions. And the first sub-theme was internal agency. So the interventions helped women to grow in their confidence, grow in their self-belief, and form that positive anticipation of the birth, which is so important. And the first woman said the image of the child was clarified and positive emotions arose, allowing the bonding process to start. And this was through art therapy. And then another woman said there was a complete focus on fear as well as anxiety and hopelessness. And this has been replaced by an expectation that reflects more confidence. And this was a person who participated in ICBT. However empowered they were and however much internal agency they had, external factors play a part. So this was our second sub-theme under feeling empowered. So the attitudes of healthcare professionals, partners, and supportive peers were important. Feeling listened to was vital. So partners and supportive peers helped respectful, trusting relationship with the midwife and the ethos of the unit. So woman-centered ethos. And actually, it was really nice to hear that from Paula this morning as well. So this woman said, it was obvious that they had read my journal and my letter of delivery. They totally knew what I wanted and were empathetic. It was great. This was a woman in the midwifery counselling. And the second woman said, I knew the midwife would help me and that I could choose the mode of delivery. I knew that if I requested a cesarean, I could have one, but I wanted to give birth in a natural way. The team gave me a sense of security. We worked together, they took great responsibility, and we were prepared for a traumatic birth. And that's important. I think it's important to acknowledge that women actually do, if they have trust in the team and they have a belief that they're going to receive that compassionate, respectful care, then they actually can cope and they can face adverse events. And actually, it is possible that they can perceive the birth as positive. Sadly, in one study, the story of 5 women who had a vaginal birth despite requesting a cesarean section was described. And these women described not feeling listened to or being heard, despite being part of the team midwifery intervention for fear of childbirth. The obstetrician was not willing to engage with women in a dialogue about fear of childbirth, resulting in a sense of disempowerment and decision-making about childbirth. So we need to all be singing from the same hymn sheet. There's no point in introducing an intervention where we have this wonderful team of midwives and then they go on to the labour ward and experience a completely different, insensitive and, I suppose, judgmental experience. So moving from empowerment, the interventions helped the women to manage the fear with a sense of security. And the first sub-theme in that was coping in times of uncertainty, which is really, really important. Some of the fears women had were worrying about the credibility and competence of the midwife. They feared not being treated with dignity. They feared lacking control. And they viewed that the midwife was in control of the birth. The interventions helped women to move from feeling that they would be unable to cope with labour pain prior to the intervention to viewing labour pain as having a purpose after the intervention. And they valued a trusting relationship and emotional support. This woman said, I'm sure I could have managed it physically, but not mentally without the support of the midwife. She was my voice all through the birth. She was totally in control. I could trust her, and she guided me carefully throughout the birth, despite the fact it was unpredictable. And this was a woman who participated in team midwifery. And then finally, women were able to manage the fear with a sense of security when they reframed the emotions about birth. So before the interventions, women avoided talking about birth. Remember, I spoke about their feelings of disgust and just not being able to even think about the birth process. The interventions helped women to actually prepare, have their questions answered and get practical tools. And they started to have an active role in the birth process instead of just being passive. We needed to work with women who had birth trauma by acknowledging their special specific needs and by reviewing their birth notes, and this helped them to move forward and handle the upcoming birth when they had an understanding of what had happened in the previous birth. And this woman said, I didn't become less afraid, but I got some help to actually put my fears aside sometimes. So it's important to see that actually maybe the fear won't resolve, but we just need to help women to cope and to manage and to get to that place of birth and to have a satisfying and a positive birth experience and to aim for that. So in conclusion, midwifery continuity of care was a significant support for women in general. And the lack of an agreed definition of fear of childbirth is one of the main issues when it comes to providing interventions and evaluating them. So we have many different definitions for fear of childbirth. So how can we provide evidence-based interventions for something which we actually don't have a good understanding of the etiology and the underpinning theory? All of the included studies use different methods of defining fear of childbirth. And there's a broad spectrum of fear, and fear could be triggered at any point. Therefore, women's needs might change. It's challenging for midwives deciding when to refer for specialist support. And I suppose this is actually one of the reasons why I started this PhD. I was working in London and I was working on the high-risk team, and we started to get referrals for women with fear of childbirth, but actually they didn't have a pre-existing medical condition, which was the requirement for being referred to the team. But there was a need for specific care for these women with fear of childbirth. So it's challenging for midwives to decide how to refer, who to refer to, and when to refer for specialist support, because obviously there's a normal level of fear and then going up to that phobic level. Healthcare professionals require education to ensure the requisite awareness, knowledge and skills to provide compassionate and sensitive and non-judgmental care. Oh, sorry, my earphones just died. That's okay.
Oops.
Hope you can still hear me. Okay, perfect, sorry. I'll just put these in just in case. I've only one slide left. So we need obviously qualitative research outside of Scandinavia. So what next? These terms have become interchangeable by clinicians and the general public over the last decade. However, using the term tocophobia might not always be accurate or helpful in pregnancy, since fear might not be psychopathological or situated within women requiring psychiatric assessment and treatment, but rather normal and rational, caused due to medical routines or increased pressure on health systems, staffing issues, and reduced availability of support leading to negative expectations of birth. In 2 intervention trials, women did not feel listened to or understood despite midwifery support for fear of childbirth, as they felt their obstetrician was not sympathetic. We need to normalise the conversation around childbirth fear. We need to take it seriously, be sensitive to individual needs, and empower women to ensure a positive birth experience. Midwifery care is moving towards a salutogenic approach based on a theory by Antonovsky. This approach focuses on supporting health and well-being rather than pathogenesis, which focuses on risk and problems. A positive approach to birth preparation, focusing on cultivating positive emotions around birth and designed to empower pregnant women, can transform the birth experience. Further research is needed to understand the etiology of tocophobia in order to provide evidence-based interventions. Now more than ever, compassion, sensitivity, improved knowledge, awareness, and understanding is vital to support women with childbirth-related fear to have a positive birth experience. So thank you for listening to my research, and I'm going to leave you with my reference list. And any questions.
That's great. That's great, Maeve. Thank you so much. That's a huge amount of work and fantastic. And I mean, I was just jotting things. I think I think you rounded off beautifully by highlighting that we can give things labels, but all women must have fear because it's a normal kind of human feeling to be anxious about what you don't know about. So for first time mums, they would be anxious, and it's kind of grading that degree of what's normal, whatever that is, and actually asking women. I wonder if we always ask women what they do feel about the fear of birth.
Yeah, well, I think if we make time to speak to women early in the pregnancy and, you know, even myth bust, you know, ask them what they expect about the birth. I don't think, you know, we don't always make time to ask women early in the pregnancy. In Sweden, they ask at the booking appointment. And I don't know that we need to actually be using necessarily a screening tool and, you know, having a questionnaire, but simply just asking, have you thought about the upcoming birth? And someone will say, oh my God, no, I haven't even considered it. I couldn't, you know. And I actually do think in Ireland as well, we do have this kind of culture of, you know, waiting for the 20-week scan, and we kind of have this anxiety around kind of acknowledging the pregnancy. And actually, it's really important to speak to your bump and to, you know, acknowledge it as a pregnancy and as a baby, and to make that bond during pregnancy and to form positive emotions. We could see that through the evidence that actually women can be prepared and they can cope even in the face of an adverse event if they feel prepared and they know what to expect. And even, you know, sometimes having that labour ward visit so that they know what to expect and they're not thinking, oh my God, I'm going to be there on my back with my legs in stirrups. Actually, no, labour wards are welcoming, warm places, and there are lovely birth environments now. And, you know, that woman-centred ethos on the unit as well, I think, is really important. That women valued that woman-centred ethos and that relational, trusting relationship with their midwife. So we really need to be aiming for, I hope it came through, that we need to be aiming for continuity of midwifery care.
Oh, that's on my little jotty paper. I've got continuity and power, relationship and feeling of safety for women. And in my mind, I was thinking of Paula's images of those lovely rooms with their birthing pools. Absolutely. But before anything, I've got a couple of questions. I've got a question from Helena Gorman. Hi, Helena. She says, have you found the concerns and fears of childbirth are listened to more often or quicker if they are private obstetric women?
We didn't look at a comparison between private and public. There weren't enough private women to take part in my study in Ireland, but I suspect that probably women with fear of childbirth are more likely to attend private practice because of that relationship and because of that trust. And actually, because they don't, you know, there is actually a lack of knowledge about the benefits of midwifery care in Ireland. I don't think it's in our culture to, I mean, these domino schemes and things are all very new. They're only in the last number of years. And so I think that actually, as our generations come through and more people have experiences with continuity midwifery care in Ireland, then, you know, the word will get out. And like Paula was talking about the water births, it's similar. And with the home births, she was saying there's more women inquiring about home births now in Ireland, because obviously we have one of the lowest home birth rates in the world. But yeah, I do think that women attend private care with fear of childbirth, but I actually think that it's to do with meeting the same person.
Continuity again.
You know, and not necessarily requesting a cesarean section, because it's important that one of the findings, you know, in that Irish study, some women actually feared intervention and cesarean birth. They really wanted to have a normal birth and a low interventional birth. So, you know, we talk about fear of childbirth and we usually associate that with requesting a cesarean birth, but I think it's working both ways, and it's actually individualizing that care and recognizing the individual needs of that person. And because obviously fear of childbirth is associated with many different things like intimate partner violence and rape and sexual abuse. I didn't go into that in this presentation, but we know that we need to be trauma informed and we need to aim for universal trauma informed care. So then it's just, I suppose, we are at a place in the UK, more so than in Ireland, I suppose. Although there has been ring fence funding, as Linda pointed out, there has been ring fence funding now for the National Maternity Strategy.
Yay!
But yeah, moving towards interventions for fear of childbirth, I think that at the moment, because we have a lack of perinatal psychiatrists, and in general, you know, not every woman has access to timely referral to a perinatal mental health team, unfortunately. I think in an ideal world, you would be able to do that. But I think that there are lots of, you know, ways that we as a healthcare system can work towards women having trust in us. I think that's really sad that women have lost trust in us as healthcare professionals, and that they would hear a story from a sister or a friend saying, this happened to me, a midwife did this to me, or whatever it might be. I think we need to really build on I suppose, our public image as well. You know, all of these things are really important. And I think that there is some excellent Instagram posts out there. You know, there's people that we follow on Instagram, and you're thinking, yeah, that's brilliant. Like, you can see sharing those positive birth stories, and women can do it. And Paula's study publishing the water births, you know, that women are having water births in Ireland. Okay, it might be a small number of women, but it happens. Birth happens, and it is joyful, and it is positive.
So we're aiming for the salutogenesis approach, definitely. I could talk to you forever, Maeve and Paula and Linda. You've been absolutely fantastic, starting off the festival so brilliantly with all these key items that we as midwives need to know. And I think the sort of our role in making sure women really get a good experience is so fundamental and so important. And so thank you very much to all of you for this morning. Been absolutely fabulous.